Hello, I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University. And in this segment, I'm going to be going over something called MOGAD. Let me give you some context as to where I got this topic from. I was actually attending the World Congress of Neurology that was taking place, and I had numerous posters in there that I presented. Along with that, I actually attended many of the lectures, and one of them went over something called MOGAD, and we were going over actually in that day demyelinating diseases such as MS. So this has many clinical features that actually resemble MS, multiple sclerosis. Um, what does MOGAD stand for? You might be wondering. Myelin oligodendrocyte glycoprotein antibody associated disease. Um, a lot of the symptoms are not specific to MOGAD. However, there's commonalities that many MOGAD cases have. Um, so oligodendrocytes usually are um, some of the cells that are actually creating the myelin sheath. And myelin actually allows for the electrical impulses that create nervous that create the nervous neurotransmitters. Allows for axon to axon jumping for the neuronal activity. Um, so this is an inflammatory condition, autoimmune attack of the central nervous system, and predilection for children. Um, and so the background, this is a protein that was a breakthrough in 2007, and this is typically immunoglobulin G, IgG associated. So what are the symptoms of MOGAD? The epidemiology MOGAD are limited mainly because MOG, IgG, immunoglobulin G was discovered only in 2007, and widespread testing is not available. So the idea is that the epidemiology is actually lower than what it really is. And children account for up to half of reported cases. So the female to male ratio is 2.3 to 1 for MOGAD ratio between female to male. And then the onset is typically between 20 to 30 years. So these are what is part of MOGAD. There's clinical features that are disease specific and highly characteristic. And these are acute attacks. And what I was told actually within the lecture, that optic neuritis is the sign for poor prognosis within this disease. And this eventually leads to visual loss. And then something called acute disseminated encephalomyelitis results in altered mental state, focal neurologic features, and features of transverse myelitis. And transverse myelitis often causes limb weakness, sensory loss, and bowel, bladder, or sexual dysfunction. So there could be a monophasic experience or relapse course. So something that is common of demyelinating diseases is that you'll have the initial episode, and then you might have a relapse of the same episode of the same disease later on. And so a lot of times you have to ensure that what you are going through, if you have MOGAD, is actually doesn't relapse. And there's some therapies and medications, new ones on the horizon that are there for MOGAD. So this goes into more detail about how optic neuritis is presented. Again, transverse myelitis is potentially the deficit of having bowel issues, bladder issues, and sexual dysfunction. And then there's seronegative, and then the clinical syndrome of ADEM, ADEM. And this is characterized by polyfocal CNS episode. So there's multiple focal points that lead to, for instance, optic neuritis and loss of bowel and bladder. Um, in MRI, abnormalities, including largely poor demarcated lesions in the white matter with or without gray matter lesions. So that sums up. Sometimes people have seizures and additional syndromes that are associated with MOGAD. And then you can go into this on your own. There's a lot of components, for instance, MRI with and without contrast, orbits, and with fat saturation images, brain, and spinal cord. Um, so this is up to date, and a lot of the various diseases are actually included in up to date. And you can look for red flags, differential diagnosis, and the guidelines. And then there's summary and recommendations, and in terms of how do you distinguish this between MS? And oligoclonal bands are positive in only 5 to 20% of patients with MOGAD versus 88% of patients with MS. So some of the same signs are there, however, the frequency is actually not the same between MOGAD and MS. So as we get to the end of this article, I hope this has provided you with some insight. Thank you for listening.